y'all put for your experienced nurse?
Our experience,
Hmm?
we did sepsis.
Chest pain.
Sepsis, chest pain, CHF. Okay. So basically the high acuity patients. Did y'all change anything up differently?
We just did the DKA, so we gave the DKA to the
Experienced nurse?
experienced nurse.
Okay.
So we had CHF for
Chest pain.
separation, DKA, and then sepsis for the primary RN.
Good. How hard was it to make these decisions?
Not that bad.
Not too bad?
Uh,
Y'all didn't like it over here, I'm sure.
No.
Okay, delegating your nurses to, these are what these nurse leaders, charge nurses do every single day, okay? So getting you in that mindset. All right. Everybody has their staff assigned, everybody has every patient in a bed. Okay, so now, let's throw some things in the mix.
We knew it.
Because we're in a 12-hour shift, we don't just make our assignments as we want. So we have different events. So event one, your afloat RN expresses discomfort with an insulin drip. Request different patient assignments. So does that affect any of y'all?
No.
No? Did anybody give the insulin drip to the float nurse? Y'all did?
We're not done.
Oh, all right. Okay, y'all almost finished?
We have like
Two or three more? Okay, we can go back.
Okay.
It's okay, we can continue.
We can continue? Okay.
Yeah, we're
course.
good, I mean.
Okay, so this is something that we might have to consider, all right? That float RN can almost be like a new grad RN in a different situation. If you floated me and a mother baby, I would have extreme discomfort in taking care of patients. So you would have to treat me like a baby nurse, as I call it, all right? So you have to assign that appropriately. You have to delegate me appropriately to my patient assignments. And then if I come to you and say, hey, I need a different patient load, then you have to readjust your entire staff to account for that, all right? So that might affect y'all. Your telemetry patient with chest pain develops ST elevation. Need to reevaluate your staff and determine if assignments are appropriate. So did anybody give that new grad nurse the chest pain? Everybody gave the experienced nurse chest pain? Man, y'all are doing delegation a little bit better than you thought.
What? You need to have a little bit more faith in us. You did told us very well.
I remember on the benchmark, there was a question like number 1, but it was like, your CNA refuses to help a patient with contact isolation, what's the best way to like respond to them? What is it? Like, what is it? I know that's.
Ask them why they're discouraged about it. Education on the proper technique for isolation. And then if they still feel uncomfortable about it, then you can assign the nurse or another CNA or something. I don't know the answer towards it for you.
remember that question. It was, the tech said that they didn't have their N95 fit, but it
Yes.
wasn't anything that needed an N95, you could just use the regular
Okay,
ones.
so
So you just
they-
educate them.
Re-educate is probably gonna be the big one on that, so.
Okay, thank you.
So everybody put this one in experienced nurse. This is ST elevation, that's immediate intervention that we need to take account of. So we probably need someone more experienced for this floor, to take care of this patient. Alright, this one's gonna change some things up. Event 3, ED requests admission for a septic isolation patient. So you need to reevaluate your staff, determine if their assignments are appropriate, and determine your patient room assignments. That septic one that was from earlier doesn't need isolation. Okay?
You didn't say we had an extra room.
Yeah.
We don't have any extra room, so what are we gonna do?
We're gonna reject it and it's gonna stay.
We're gonna reject something in the ER, they need a bed right now. Is there any possible discharges?
You're gonna try to get rid of.
We're gonna get the dementia patient to the nursing home.
DC.
The GI lady, as long as their vitals are stable.
So, she said GI bleed, as long as their vitals are stable. They're a very low frequency, right? They really don't need a whole lot of care. So maybe I need to reach out to my physician and ask for, possible transfer orders, step-down orders.
The dementia patient?
Dementia patient, what about them?
Send her to the nursing home.
Send her to the nursing home. Well, she's here for a reason, she needs to be watched, right?
Well, med
Send her to med surg or
Send her to
something.
med surg or psych.
So she can run around naked?
Jerry's side, go ahead.
Sort that out.
Alright, your CNA calls off mid-shift. So now, you have 6 nurses, or 6, patients for that CNA, now you have 12 patients for your CNA. Are they gonna need some help?
You need your nurses to pick up the patient too.
Okay, so she said, grab a nurse to help with care. Alright, can't y'all do vital signs?
Well, of course we can.
Alright, humble yourself a little bit, do some vital signs. Can y'all wipe butts?
Yeah.
You can wipe butts, right? Just because you have an RN degree doesn't mean you can't do that kind of stuff, okay? So you may have to reevaluate. If you have your experienced nurse, a lot of y'all gave them all 3 high acuity patients. Are they gonna have the time dedicated to take care of some of those other, patients? Y'all put the LPN with some of the lower acuity patients, right? So maybe they can go and help that, CNA or that tech with those patient care items. Maybe they can almost tag team it, right? Okay? Right? Family complains that their family member has a lack of supervision, so this is your dementia patient, and feels that they are not safe. So now we gotta reevaluate our staff to make sure our patient is taken care of. Remember, we don't have that extra CNA anymore to keep an eye on them.
Better get a patient
Get
center.
that thing, that be in the room.
That little jelly.
Alright, tell a sitter, we might have that an option, a sitter, security sometimes brings up people, we have to think about that. Can I reassign a nurse or put them closer to the nurse's station? I didn't tell you where the nurse's station is, but that's okay. So maybe they need to go back to bed 1, but bed 1 is isolation and telemetry, and I've already gotten a admission from the ER that needs isolation. So those are some things that you have to take into account from there, okay? So patient in bed 5 is ready for discharge. Oh, that's good, because I can, get my septic isolation patient up, right? But the physician has not placed an order for discharge yet. And then the physician will not be available for another hour. So now you have to wait a whole another hour. ER still calling you, hey, can I get a room for this isolation patient? They're yelling at you. ER's full. Tell them no, it is what it is. But these things happen. Right? That physician never puts in that discharge note. Those discharge med recs, those kind of things. So we gotta figure out what to do. Call that physician, get them on the phone and say, hey, we're getting full. I need you to put in your discharge note. Are we able to discharge? Get this patient ready for discharge, all right? If you had, an experienced nurse for that, are they able to discharge this patient? Can the LPN discharge and educate?
No.
No, we gotta get one of those RNs to do it, right? So we gotta consider who's able to do that kind of stuff. Maybe we have to delegate that task out to a different nurse because we delegated or we gave the assignment to the LPN instead. Okay? Alright, event 7. Now surgery is requesting a bed for a patient with a cholecystectomy. The patient needs a telemetry monitor. Okay? So only beds 1 through 4 were telemetry, right?
Mm-hmm.
Alright, so now I gotta consider which patient am I gonna move out? Which one doesn't really need telemetry?
You better call it.
So Drew, what patient of yours doesn't need telemetry as much?
The DK, if they transition, could probably come up to.
Okay, does a DKA truly need telemetry?
Not really.
Not really, okay. What about for y'all, which one would y'all move out?
COPD.
COPD exacerbation? Y'all put up COPD exacerbation too?
Mm-hmm.
Okay, good, I like that. So these are some of those events, some of those things that you may run into as a charge nurse or in a more leadership role. And you have to remember the roles, responsibilities that your LPNs and your RNs, your new grad RNs have, and delegate appropriately. Also takes into play your prioritization, your ranking system for your prioritization. That's what we're gonna talk about next. So your levels of prioritization. In your module, under your leadership and management, there's a lot of good resources under that section. Please don't just scroll down to the bottom and look at the podcast and the other stuff in there. At the beginning, there's a thing called prep work. I don't know if anybody looked at it or not yet, but it's called prioritization, nursing interventions, roles, something along those lines. It's at the top. It talks about the levels of prioritization. It's like a 2-page read. There's like 3 or 4 paragraphs. It really breaks down these levels of prioritization very well. There's 4 levels in that article, but I only put 3 up here. So level 1 is going to be your most critical, your most serious type of patient, a level of prioritization. With that, these are these life-threatening conditions. If I don't do something immediate, some type of immediate intervention, things are going to get serious in a hurry. So your ABCs, your airway, breathing, and circulation. Other things might be like trending vitals, labs, something that is really out of whack. So if my patient goes into VTAC arrest, probably need immediate intervention to save their life, right? So your level 1 priorities is really your big thing is going to be your ABCs, those life-threatening type of conditions. There's also another one that's kind of on the side, and people don't think about it a lot, is patient that's about to experience a fall or immediate injury to themselves. You could consider that in the level 1 prioritization. If I don't do something immediate, they're going to hurt themselves. Patient getting out of bed. That dementia patient that we just talked about. Maybe she's undressing herself and is fixing to trip over her cords. She's fixing to fall. Okay? You have level 2 prioritization as well. So things like mental status changes, acute pain, nausea. Acute pain doesn't really matter in the grand scheme of things, right? It does eventually, but in the immediate, is it gonna kill my patient? Is it gonna hurt my patient? Not necessarily, right?
Could you argue, so like mental status change, would that be kind of different from level of consciousness, I guess?
It would kind of be in the same boat. LOC,
So would that not
changes in
kind of
mental
be
status.
more so than one?
These kind of fluctuate, so you can go between like a level 2 and a level 1 prioritization pretty quickly. Okay. Abnormal labs could be in there as well, but it's like potassium 3.4. You know, that is abnormal, but is it really abnormal? Kind of. All right, so that's going to be in your level 2. And then your level 3, this is about discharge planning, education, maybe scheduled pain medications, those kinds of things. And your level 4 is kind of reinforcing that teaching, your discharge planning, that kind of stuff as well. So my patient's ready to discharge at 12 o'clock today. Do I really care? In the grand scheme, not really. I know it sounds bad, but if I don't get him ready till 12 o'clock, it'll be okay. How fast do I need to react to these threats? Okay, I got till 12 o'clock to discharge that patient, so I don't have to really do it that fast, right? My patient has an obstructed airway. I got to get that clear real fast, right? My lab values. My mental status changes, nausea, vomiting, pain. Yes, I need to get to that, but I don't need to get to it as fast as my obstructed airway. So that's how we kind of work with our levels of prioritization. Like I said, read that article that I put out there on Canvas. It's a really good resource for you, okay? All right, we're just gonna talk through these. If you want a handout, I can give it to you at the end of class. That's okay. So admitting physical assessment, RN, LPN, or other tech?
RN.
RN, big key word there, admitting, initial. That's gonna be your key word there, okay? Implementing teaching,
RN,
RN, good. Why?
because it's initial teaching.
It's the initial, right? Implementing, starting out, initiates. Remember, initiating is important. Okay? Reinforcing teaching. LPN, RN can do it too though, right?
Right.
Okay, but I can delegate that to the LPN because the initiation of it has already been done. Alright, hanging blood products for us. RN, okay, good. Hanging IV piggybacks. RN or the LPN, right? Either way. Good. IV push medications. RN for us. For us, okay? Decision making.
RN,
The doctor.
wait, so,
Depends on what it is.
Depends on what it is, so what could it be? RN, LPN, or CNA?
all of them,
All the above, right? RN does decision making, right? LPN does decision making. Doesn't the CNA do decision making too? I need to decide if I need to clean up a patient or not, right? So that's a very broad statement, decision making. Probably need a little more detail if you're gonna truly answer that question, right? Central line dressing changes.
RN,
Okay, good. If you're certified as an LPN to do sterile changes, sometimes they'll allow the LPNs to do those as well. Okay. Hanging IV fluids,
RN and LPN,
RN and LPN, all right? What about bathing a patient?
all of them,
Good. Administering bedpan, I don't know why I say it's that, but administering bedpan.
all of them,
All of us, right? Okay, here's your key difference here. Hanging IV fluids to a triple lumen catheter.
RN,
Okay, can an LPN touch a triple lumen?
no,
No. Good. Obtaining specimens.
RN and LPN,
All of us, right? Have you seen a tech stick people before? Get urine stuff before? Alright. Or if it's a sterile procedure, then we could let the CNA do it, right? Okay. Inserting a Foley.
RN, LPN,
RN and LPN, good. Starting an IV,
RN, LPN,
and then vital signs.
all,
Alright. Accu checks.
all,
Good. Simple dressing changes.
LPN and RPN,
LPN and RN, and then we have complex, that's the difference. RN, remember those complex procedures, more extensive type procedures. We want to delegate it more to the RN. Yes,
So starting IVs for all of us, it's only RNs?
RN and LPN.
Okay.
It's gonna be difficult. Try to get your mindset off of East Alabama. Same with you. Who else is an LPN? Your scrub tech stuff, kind of put it by the wayside, forget about it for a little bit. Your radiology stuff, kind of put it by the wayside for a little bit with some of this stuff, okay? Certain IV push medications, if you're trained, non-narcotics, you can do RN or LPN. IV push medications, narcotic wise, that's gonna be delegated to the RN only, okay? Orientation to the hospital setting, RN, good. But we can also do LPN, right? Can they orient them to the room?
Yeah.
Is that true education?
Yeah.
Alright, what about the CNA? Here's your call light. This is how you get the on button. Alright, probably gonna need a little more information if we truly need to answer this question. That's good. History interview for hospital admission.
RN,
Alright, that gets a little more involved, a little more in depth. I'm taking that initial admission assessment for there. Implementing the plan of care. RN, good. We're responsible for providing that overall care, implementing that care that the physician has prescribed. But then we can delegate that stuff out. But we're still overall taking care or implementing that plan of care. Now the difference here, reinforcing that plan of care.
LPN,
LPN, can a CNA do that too though? Can't they turn their patient Q2 hours? That's implementing plan of care, right? Or reinforcing that plan of care. But it's still up to the RN to make sure when we delegate those things that it gets taken care of. Right at 7, okay. Last one is in here. I will post this PowerPoint, so we'll have all the stuff in it so you can go back through and look at it. I know the one that y'all had on like 5 slides. so y'all didn't see all this stuff beforehand. And I'll give you the answer key for this stuff as well. Please look at your prioritization and delegation stuff at the top as well. There's a new visual thing that I found that creates stuff to summarize your content. That's pretty cool, that I like. Just show it to you real quick. Okay, so that really breaks down and summarizes my entire lecture into one big picture. Gives you kind of a good visual of it, so that's something new, something different that I found. I really liked it too. Of course, there's the traditional podcast in there as well, so there's a lot of good resources out there for your leadership and management stuff. All right, next week we're gonna cover neuro. Your neuro content should be out and available here by the end of the week. If you have questions about preceptorship, I know that was a lot thrown at you at one time. Please reach out to me, come by my office, you know where I'm at. Please make sure you have all your information, so your letter, your preceptorship manual, your contract, and your nursing rules, when you go to your preceptor, okay? If you happen to misplace it or lose it, look under your preceptorship information tab, your module. All the documents that I gave you are there for you to download and print off again if you need it, okay? So if you lose that kind of stuff. If you have questions or concerns about reaching out to your preceptor, please let me know, okay? I'll be here and available if you have any last minute questions. There, everybody send the roll. All right. Good job, guys. Have a good night. Thank you so